Must have a big note in front of you.
I do. I got my little stickum here. I said, I will not forget today. All right, let me bring up the agenda. Let's see here. 26. Okay, can y'all see that, please?
Yes.
Everybody see it? Okay, all right. So we have to do the official part of the meeting since this is an official board meeting. So I'll call it to order. It's whatever time it is here, 11:05. We're going to make a motion to dispense with the minutes in the financial report simply because we're going to focus on our discussion with Benistar here. All right, so could I have a motion, please, to dispense with the minutes in the financial report?
I make a motion, we dispense with the minutes and the financial report.
All right,
Second.
Connie,
Second.
okay. All in favor? Aye.
Aye.
All right, thank you. All right, you can read on the agenda all the financial stuff there. We will get into it, review it in detail next meeting. All right, let me just start. We're going to get into the initiative here. Obviously, our big initiative is Benistar and the update and all that stuff, but I want to make a kind of an opening statement here. And then I would like to hear an opening statement or response from Benistar, and then we'll move forward to the specifics or the details. It's been a long time, as I've said, and I sent the email, and you all appreciated that from Benistar, my timeline and exchanges. You know, 2 years. Really, if you take off 6 months where from like July to December that I was moving, trying to sell my house, moved to Florida, moved 3 times. That kind of knocked out 6 months worth of progress, but we continued to have many, many meetings and changes and revisions and updates and then revisions again, and then missed deadlines 4 times. And, you know, again, I was partly to blame for some of that. Benistar, I believe, was blaming it. And my opinion, after listening to, you know, all the talk between us and Benistar, is a lot of it had to do with Anthem. Listen, they're dealing with big projects. The New York Sedan sent a thing about New York City and the big project down there, 250,000 people. They're big fish to fry. And so they had big things to deal with and other things to deal with. And I'm just probably jumping to a conclusion here, but we were the small fish to fry to get this done. So that was, I think, a big part of the delay. Today, there's going to be a lot of paperwork to digest. I sent it out to the whole board for review. Hopefully you guys got a chance to look through it. And I know it can be confusing, and we've gone over this time and again, but everybody needs a reminder. We need to refresh ourselves on what is being offered, how we're going to get there, how we're going to complete this and finalize this darn thing. So that's all important to us as an organization. We want to bring this thing to completion, finish this up and kick it off. One of the worst things for me has been kind of a credibility with our membership thing that not constantly, a number of times as we set dates, foolishly, I guess, I put it out there to our membership and told them, we're going to kick this off in January. We're going to kick this off in March. We're going to kick this off in June. We're going to, you know, and each time that kind of affects your credibility when you don't complete that with the membership to say, what's this guy talking about? He keeps telling us this thing's going to go and it's not going. And I'm sure they're waiting for us to do this. So we need to get this done. And I think from what I've received so far in some of the sideline conversations, I think we're moving in the right direction, and I'm hoping we can get there timely, as soon as possible. We can get there and get this thing going. So that's my statement. And Don or Glenn or Mike, anybody want to make a statement from the Benistar side?
I mean, I would keep mine very simple. We're happy to continue to participate, and we're steadfastly focused on completing the task at hand. And I don't really have much to add to the history of it. It has been a longer than usual road, but here we are all today. So let's do what we can to make the most of it.
Glenn or Mike want to say anything? I mean, this is an official record here, folks, so I don't know if you want to, Don said what he had to say and you guys want to just be quiet or what?
No, well, I just want to thank everybody for their patience. It's been a long road, but Don and Glenn are the best at what they do, which is why Nancy came to me and why I brought them to you. And our partner, Paul, has built out an absolutely fantastic, beautiful website. We're ready to go, finish it up. Once we get through today's call, we're all very excited about this and just thank everybody for their patience. That's all I got.
Okay. I think everybody's aware in that timeline that I put out there, the many exchanges of documents and emails. It's pretty intensive. The amount of work we've done over this past, again, taking that 6 months out, at least that year and a half, we certainly have done a lot of work, and it's time to finish it. It's time to do it, get it done, as Don said in his email, get her done. Okay.
Amen to that.
Amen. All right, so Don, where do you want to start? You want to, our expectations are the things that I listed in that email of things that we need to get done. We got the agreement. I know you don't want to get into a bunch of conversation. You said limit discussion, but that plan that's out there now, the new plan from Anthem, that looks very nice. There's some things that Ed and I need to talk about legally or legalistic stuff that we need to expand on or enhance or do something with. But basically everything, as you said in your email, were discussed in previous discussions and emails, and Benistar responded, and you tried to include as much as possible. And where you couldn't, you said, you kind of gave a short explanation of why you couldn't fulfill something to the degree that we wanted. But I want to kind of turn it over to you. Do you want me to put that up there, that agreement up there? Do you want to go over it? Do you want to go from your email and discuss?
Let's start backwards. Why don't you throw up that last thing that I sent you, that one-page PDF? Can you throw that up there?
Yes. Let me get that. Hold on.
And the reason I want to start there is I think it just, why are we doing what we're doing? What is the core value proposition and the mission, and have we captured that? I'd like to do that before we go deeply into details. So if you can
hold on,
that up, that'd be great.
This thing is blocking my screen here, so I got to find out why. Get out there. Not letting me get to my email here. Come on, why is it doing this? Let's see if I can get it on the other screen. Yeah, I probably can. Okay.
John, can
There we
you,
go.
I was
All right.
saying you could share your screen with Don and he could do it, but all right.
Yeah, let's see here. Are you seeing the one with the email that he talked about, the individual plans and the rates? Are you seeing that? No? All right, let me,
I'm sorry, what?
are you seeing the email up on the screen? No? Yes, no?
We're seeing the agenda.
Okay.
Agenda.
No, I don't see it.
All right, let me go back to. Okay, now you're seeing the points. Don, you want me to bring up the actual document, don't you? Is that what
Yeah,
you
the
want?
PDF document's what he's looking for.
Okay,
29 pages.
No, just this one pager here.
Oh, okay.
The one thing you have, right there,
Okay.
click on that GURBS group MAPD.
All right. Are you seeing that?
Hasn't opened yet. It should.
I might have to do a new share to get it up. Let me see. Yep. All right, now let me make that bigger because obviously you probably can't see it. Who's that? Who did that?
I don't know.
That better? Can you see that?
Yeah.
Okay.
So I'm just going to say a couple words, and I'm not going to really go through this, but you should share this with the board, obviously.
Yeah.
So when we started this journey back in the 1700s or whatever it was, we considered a couple of different value propositions. One of which was, whether we should, directly compete with individual products in the market. And we wanted to think through that. At some point, we spent some time talking about more of the med sup sort of market, and a little bit talking about zero premium plans and some other things related to that. And kind of where we alighted, maybe we didn't say it explicitly, but I think we made it pretty clear, was that we wanted to be able to offer something to people that would resonate with them and that they could not otherwise achieve themselves by going to Medicare.gov or to going to the individual market. And therefore, this is sort of the approach that we've taken in building out these two plans. And so what are those things? And they basically fall into two categories. Category one is cost, and category two is the level of benefits. So taking category one, which is the easy one, the cost part of it, as I started in this opening remark here, there are plenty of zero premium plans if you're willing to accept a local market type network, and you'll have very little out of pockets if you follow those rules. There's some Medicare Advantage plans that have that. But in comparing this to, folks who probably want a more robust and more flexible and more complete set of benefits, we've picked some, we had Anthem pick them, but we picked some just, some comparative stuff that shows kind of our high level plan. We wanted one that was kind of around that $200 mark, another one that's around that $100 mark. Keep it easy. And there's nothing magic about it, but, it feels about right for the market. And if you compare it to the individual med sup market, for example, it compares pretty favorably. If you're age 65 in some markets, you can get a cheaper, Plan G, which is a popular plan now. Obviously, Plan F was a very popular plan, but still longer offered in the market. But you still have to go out and get prescription drug coverage. And so that in almost all circumstances will push those premiums significantly above where we are today with a less robust set of benefits. So I think in part we can say that we've achieved, at least in the benefits and affordability aspect of it, what we had outlined previously in terms of our mission. And then the rest of what we're going to go through, which is not reflected here, is, what's the particular mix of these benefits? Where's the right, kind of inflection point about a deductible or a copay level, the differences between the plans, the level of benefits in the prescription drug area, et cetera. This little piece is just intended to highlight a couple of the biggest factors. So the plan that we've put together in this group environment has some benefits that are only available in the group environment. Those include the ability to go to any provider who accepts Medicare assignment, whether they are a Blue Cross contract provider or not. It's in all 50 states, and in fact, anywhere that Medicare provides services, so territories, Puerto Rico, et cetera. And if you move about the country, if you're in California one day and then in Arizona the next, et cetera, you don't have to get referrals. You go wherever you like, however you like, et cetera. So that's a big advantage versus the individual market where these are not available. And the reason they're available in the group market but not the individual market is they are available through an exception provided to the group market. The second thing is we've highlighted prescription drugs. It's something that we think will motivate a number of retirees when they think through how they purchase coverage. It's the number one, question that we get. Hey, is my drug covered? And if so, at what copay level? And so, without doing a deep dive on that, shared, and you'll see it a little bit further, some details in terms of the structure, which we hopefully simplified a little bit in the benefit plans, but they'll have access at a very low cost to most of the generic drugs and most of the preferred brand drugs, and they will have robust coverage for the most expensive drugs, the specialty pharmacy drugs, et cetera. Through what we ended up doing is piecing together the broadest network, but then there's a preferred network where you can get some further benefit if you stay within that preferred network, and there the network is important. We will be able to support folks who are contemplating making a change, but who want this answered more specifically on a one-on-one basis. We'll be able to do that beforehand, and that'll be the number one question by far. We'll get 10 of those questions for one of every single other question. The second most popular question will be, is my doctor in the network, despite the fact that we're indicating you can go wherever you want. People just want to know. And so we'll be able to do that as well. Blue Cross has over 800,000 in their Medicare network nationally, so it's highly likely that they are. But even if they are not a contract provider, we don't care. We don't track it. It doesn't change the benefit level as long as they take Medicare assignment, for those services that are being delivered. Where do you find that those don't happen? Well, if you're seeking dental or podiatric or something that's just not a traditional Medicare benefit, you're going to run into people who are not going to take that sort of assignment. And those are where things fall out a little bit, but those additional benefits are generally otherwise not available. So hopefully they're not a burden, but a positive. And then the last thing I'll say in highlighting this is that we've endeavored to add what we view, and you may view it differently, we view as Medicare Advantage additional benefits, non-Medicare benefits. And these include some of these extra programs that we'll touch on when we go through the more detailed piece, but they certainly include things like the wellness program, which is the silver sneakers. You can go to gym and health club memberships for free, and then there's a bunch of things around healthy eating. One of my favorites is something which is a transportation benefit. It's something that as we move forward, if it gains the visibility and traction that it has in other places, we'll look to make it even more robust. This is a benefit that delivers mobility to this population. So one of the biggest challenges that retirees face is they can't drive themselves to places. And we're not talking about, an emergency or medical event driven transportation, but we're talking to the grocery store or to, go someplace in the community. So we've included a very base benefit here. It's 12 rides, but that's something that I feel is going to be a growing benefit as people move forward. It's not quite in the area of something, if you're following Medicare, just emphasis, there's something called the social determinants of health. So there's an emphasis on providing benefits through Medicare that support sort of an overall sense of well-being, and transportation is not directly one of those, but it is part of it. If you can move and be in contact with people and deliver services and don't feel that you're at, that you have to burden your neighbor or child or whatever in order to do something, it can certainly have an impact in your life. There's some other things that are mixed in. I'm not going to go through every one of them, but those additional benefits is something else that's been included, mostly with a larger focus on the richer plan. And the richer plan has robust brand drug coverage, so it has complete drug coverage through the donut hole. So all those things are included. And this is just a summary piece kind of explaining it so that when you're thinking about it and reflecting on it and saying, why the heck did we do this? Why does it matter? This may resonate better with kind of your own mission, or maybe not. And if it doesn't, then certainly provide us feedback. But I think that was what we thought was the goal and the mission. And I know there's often mission creep or changes or people view it differently, but I'll pause there. If we think that's consistent with the goal of the board, then I think we can move to, just review some of these particulars in a little more depth.
Yeah. There's also in that, there's some dental, vision and hearing coverage, right?
There is, yes.
Yeah, I just wanted, because that was important. And of course, it's a big political issue right now, an expansion of Medicare and having those coverages. And I certainly hope we get to that. I'm looking for the document. Hopefully here I can find it on my screen so I can bring the document up. I'm not seeing it for some reason. I don't know why. All right, do this. It's coming up. And on one screen, I'm having a tough time getting the thing up, and I'm trying to do it from the other screen. And for some reason, isn't it coming up? Huh. Bear with me a second here, folks.
If you provide me access, I'm happy to throw it up.
All right, let me do that, because for some reason it's not coming up in my share screen. I don't know why. All right, let me close this off. Let me give you Don. Okay, Don, I just gave you post. You can bring up that document. Now I get this the thing to come up on the bottom. What a
Can you see that?
not yet. Oh, there you go. There you go. Should be seeing it now. Everybody seeing it?
Yes.
Okay.
It's a couple walking with a dog,
Yeah. Oh,
wearing very stylish waders.
Oh, yeah. What are they, in the swamp?
Must be in Great Britain. Wellies.
I was just thinking that, wellies. That's what my son-in-law calls them.
So this piece, which you can circulate widely as you wish, has some boilerplate stuff in it, which I'm going to spend literally zero time talking about and going right to the
That was the
pieces that
welcome
we want.
part, right? Wasn't it? That was the welcome part?
Yeah, is a welcome part. And there's a little bit of an explanation about some of these, silver sneakers, hearing benefit, vision care, et cetera. I'll just talk about them when I get to the,
Okay.
but some of these other ancillary benefits, when you see, you're not going to remember what I say unless you're inclined to listen to this recording, later. But this little thumbnail sketch of what these benefits are will probably be helpful
Right.
at some point.
Yeah, sure.
In any case, so just getting to page 14, nice pictures, great
Yeah.
artwork.
They did a nice job on this. This looks good.
Do you like these bikers here?
What?
it's got a couple that are biking along. Okay, so can you see this? I'm on page 19, but this is what I'll call the financial exhibit.
Yeah.
You got that?
Yeah,
So
I
I'm not
just-
going to spend a lot of time here. You've seen something similar to this previously, but I'm going to highlight a couple things. So where you see this blue box on the left that says medical,
Right.
and if you keep going to the right, it says members 111.
Right.
So this is an amalgam of data that you provided to us that through some diligent effort, we kind of put into a census. And so they did pricing, and it did fairly reflect a diversity in geography and, gender and age and that sort of stuff. So that's all what this was based off. Does it dramatically change things? Not really, but in any case, that's if you're curious as to
That was
how
to
they
kick us,
drove that.
that was to kick us off, right, Don? I mean, we're
Yeah.
expecting to
Yeah.
have many more.
Well, we certainly hope so, yes.
Yeah, yeah.
So, and then the second thing I'm going to point out is there's two columns,
Right.
one that's one that's blue, and the other one's kind of a green going into gray. The blue one is the more expensive but more robust benefit plan, and the other one is the lower, more affordable, but with a lower level of benefits as well, or higher out of pockets.
Don, can I ask you a question here on this? You know, many
Yes.
times we've tried to revise those top two bars, you know, whether it's a Anthem, I don't care how they titled their part of it, Anthem, Medicare Advantage, but to say higher premiums, lower copays, lower deductibles, and the other one to say lower premiums, higher copays, higher deductibles.
And that will be the case. That will be the case for member-facing communications.
Okay,
You won't see any of this gobbledygook, but you
Yeah,
know,
because they won't understand that at all. Yeah. Okay.
for our inside baseball team here,
Okay.
we'll just
All
keep
right.
this.
Very good. Very good.
So this rate in the middle where it says total PMPM rate,
Yeah.
it says $200.02, and the other one says $110.04.
Yeah.
That the way that those rates are developed is there's a rate for medical, and above it it says $56.76, and a rate for pharmacy,
Right.
$143.26. And the only reason I'm going to point this out is that what I want to emphasize is that even if we changed around benefits in the medical sense, like we put in a $500 deductible or something like that, we could probably drive the medical component of this to close to zero, right?
Okay.
What drives the cost and what our core value proposition here is basically invested in the pharmacy benefits.
Right.
The pharmacy benefits are the biggest driver of cost here. And so you'll see comparatively one's $143, others $105. That by far drives it. And in fact, you know, the medical component on the base plan is $4. So
Say that
these
again, that last statement.
the medical component of that $110 on the lower level of benefits is only
Yeah.
$4. It's $4.09.
Oh,
It's
okay.
basically all the prescription drugs that are driving the overall cost. And I'm just making you aware of that. That is consistent with our core value proposition. At the same time, we are trying to achieve a robust level of health benefits. But the reason I want you to bear that in mind is when I say something later, like it costs $7 to do this, and you go, that's nothing, let's just throw that in there. That'd be 150% increase on the base rate of the medical because it's only $4, right? So really in the design world, you know, just thinking this through, a lot of it has to do with where we are trying to achieve our price point, where we think we can get value in terms of building something out. And as I say to folks, you should feel comfortable, you know, enrolling in this yourself, selling it to or, you know, encouraging your spouse or, you know, whomever to be in this. This is intended to be a valuable benefit for them at both the medical and the pharmacy side. So I don't know if there are any questions about the rate part of it, but obviously if we decide to make a couple of adjustments, it might impact the rate a little bit. But in general, we're trying to achieve those two price targets that we discussed.
The specifics of the tiers in the pharmacy, that's covered in here too, isn't it?
Yep, we're going to get to that next, benefit levels.
Yep.
Don, I have a
Yeah.
question, Don. On the rates presented, does that incorporate some type of feedback to GERS, or does it have to be built in on top?
It will have to be built in on top, and it's a minor legal point, but we have to work through it with them. Since they're not a licensed agency, it has to be under a shared services arrangement, and it's something I'll discuss with Ed and also counsel for Anthem. But it's a fair point, Mike, and yes, it will have to be added.
Yeah, that is a concern. That's one of the points I had down. I'm glad Mike brought it up, but I was going to bring it up, the fees that were mentioned and the what your email, Don, about shared fees or something. And you know, I said that's something we always try to avoid. You know,
I'm sorry. What
I
are you
said
trying to
that-
avoid? What are you trying to avoid?
the shared fees, that part that was in this agreement someplace about, back up right here. Isn't it in here someplace about the shared fees? No, right in this part. Yeah.
I don't think it is. It's just in my cover email note.
Oh, okay.
And it's not shared fees, it's shared services. And the reason for it is there's basically only a couple of ways under which you could be remunerated. One is the fulfillment of certain services or duties that would be covered under an administrative shared service agreement, or the other would be producer compensation, which would require licensure. And I don't think you want to go in that route for a couple of reasons. It would involve additional scrutiny since you're also the plan sponsor. Yeah. So anyway, it'll be appropriately covered in whatever it is. But it doesn't, I mean, you're going to define what that is. So it doesn't impact any benefit cost or anything like that. It'll just be, the fee will be what the fee is.
Well, Ed will make sure we're on the.
Yeah, well, I'll go over that with Don later and we'll figure out how to make it work. He's right. You can't share producer fees with non-licensed folk.
Okay. All right. So.
And John, before we go on, this is Glenn.
Yeah.
Has anything changed in the structure of the stipend? Retirees still have to take a product from VIA in order to be eligible for the stipend. Is that correct?
Yeah, that's a good point on those two options. I'm thank you for bringing that up. For those two options, yeah, the people that are in the RRA, I'm assuming, and I think we discussed this before, Don and Glenn, that the second option would fulfill that without drug coverage. Is that it, or do we need a third option?
You could have a third option, which would include filling it with, as you say, basically similar level of benefit, but without that component. Let's table that discussion though for right now, only because this sort of messaging is a little bit different than the messaging that you're talking about in terms of how you position it to the RRA group.
Yeah.
And we need to get into the weeds a little bit on that in terms of what would qualify for them. So in other words, I think I remember this correctly, and you'll correct me if I'm wrong, but I think the subsidy is $100 per month, as long as you take either an individual product through the exchange, or you elect, I think they had like sort of a standardized prescription drug benefit. At least they did at one point. I don't know if that's still true.
They can
You just take one or the other.
Well, yeah, you got to choose one, the Medigap or the prescription to keep the RRA if you're going to go outside for one or the other.
Mhm.
It's $1,000 a year coverage for our RRA set amount.
Oh, so it's $1,000 a year.
And if there are a couple, it could be 2,000. So
Right. So
if we're going to entice those people, we need to have in my opinion, looking at this, a third option. If we're going to try to capture any of that.
So that's the point I was going to make. Let's go back up here to this just for a second, just so I can illustrate my point. What you're indicating is you must take, in order to get that $1,000, you must take either medical through VIA or prescription through VIA.
That's
and
right.
So the point I'm making is, let's suppose that what we say is you need to take, or you're electing, we make available the base medical and you're electing to take prescription through VIA.
Yeah.
Because if you don't take prescription through VIA, this is the point I'm getting. If you don't take prescription through VIA and you elect our medical only, then you have no prescription and you don't get the $100. So that's like, I mean, that makes, I mean, I don't know. Someone was giving you $100. That doesn't make a lot of sense. $1,000, but you know what I mean? $100 a month, that's $80 a month, I guess.
Right.
But yeah. So that $1,000. But what I'm saying is, if the point of what you're doing is you don't elect that prescription drug through them, and that prescription drug through them, in terms of what we looked at the last time we looked at it, and I'll grant you it's been a year, but was generic only coverage for any of those benefits. The point I'm making is, even on the base benefit, there's more robust benefits on the prescription drug at $105 a month. So yes, you could get this base benefit for $4, and you go at the individual market for $0. But the point is, if you don't elect the prescription drugs, then it's going to cost you, you don't get any subsidy and you don't have any prescription drug coverage. If you do elect it, then you don't have the more robust prescription drug coverage, and you're back in sort of the individual market. All we're offering you is either this $4 or this, or even if you do it in the richer base, this $56 plan. Anyway, so we just have to figure out what would actually make sense. And the point I'm making is you might be better off not taking the subsidy and just saying, who cares? It doesn't matter. It doesn't help me, because if I care about prescription drug coverage, then these are both better plans that are available to me. And these other pieces are as robust or more robust than you can get in the individual market. So if
what you're saying basically is it'll cancel out the $1,000, not make it a concern.
exactly, it's irrelevant.
Yeah,
Mhm.
yeah, I guess.
So anyway, we can talk a little bit more about that, but I just wanted to highlight that. So,
Okay.
and I think it's the same is true if you go in the opposite direction. But in any case, moving on to the benefits for these two pieces. And again, don't worry about this kind of labeling. It's just whatever. It's, again, irrelevant. This will not be included in the.
I read that as
stuff.
for the 10p you can get high, and for the 25 you can't get high. Oh.
Not even sure what you're implying, but okay.
Yeah. Well, you get extra benefit, drug benefits. Maybe
Gotcha.
they're not legal, but you know.
I think it's actually just descriptive. PPO is preferred provider organization. 10p is $10 primary care visit. High is high option. I don't know.
Yeah.
So what we did, and I'll just do this pretty quickly, but in the prior version of this that you saw, there was no deductible on the high plan and there was no deductible on the base plan.
Yeah.
For affordability, we added a $200 deductible in network. And to make some difference, these were both $3,000 out-of-pocket maximums. We reduced the one on the high option to $2,750 and increased the one on the other $3,750. Unless you were hospitalized on the lower option plan for 5 days, those are unlikely to matter to you irrespective, because the copays are so low. In terms of inpatient benefits, this had been on the low option plan, a $240 copay for days 1 through 6. We reduced it here for $200 copay from $240 to $200 and reduced the days from 6 to 5. We made the outpatient hospital care, just the event-driven thing, the same as the hospital copay. It was previously either 0 or 100. I can't remember. I don't have to find it, but so that is a slight increase. This is incorporating comments that were shared by you, John.
Yeah.
The primary care visit, you asked to reduce it to 15. We actually reduced it to 10. Felt just if you're going to have it be impactful, might as well make it a meaningful difference. So this is 10, kept this at 25, kept the specialty at 25 on the richer plan, and then kept this at 40 for the specialty on the base plan. So you'll see later that we kind of mirror that same thing in the diagnostic testing when we get to that. So any questions so far? These are the major benefits, right? These are the core major benefits. Any questions on this, comments?
Anybody on
Thoughts?
the board got questions on the comparison of the high and low plan here? Anybody? No?
And you can save them all up and ask them at the end if you want.
Yeah.
Once you've bought a vial, it's yours to keep.
Yeah. Once we're prepared, don't want to talk.
So the rest of these things are, I don't want to say they're lesser benefits, but they're, more particular, more specialized benefits. So it does include unlimited telemedicine at $0 copay. It's an Anthem owned access point. So you can call up and do either video like we're doing, or you can do it on your mobile device. I don't know how you do it on a mobile device, don't ask me, but it is possible. Or you can do it the old fashioned way and just dial in. So that's available, unlimited, live health, doctor's visit online, all the preventative care services.
You were going to say something, you said in I think your email that I'll explain more on preventive care. I'm assuming that's like annual physicals, testing, diabetic tests or whatever, screenings, stuff like that. Is that right?
Yeah, what I was going to say, and I purposely didn't send this back, but if you'll recall that sort of 100-page document, which is the EOC, all of these are the Medicare covered. So they're just the mandated preventative care benefits, and there's a suite of them. There's 20 of them, let's say.
Okay.
So it's certain vaccinations, it's certain screenings, it's a once-a-year health screening. There's some additional benefits for women's health-based, and there's some diagnostic stuff. They're all covered at zero. Again, it's not like we're designing it in there. It's required by law. So it's, I mean, it just is. So I'm not gonna spend a ton of time talking about that. But it will be for each member, they will be able to look it up and see it for themselves. It'll be in that 80 or 100-page document, whatever it is. So in terms of inpatient mental health benefits, they're just mirroring the inpatient essentially. So mental health is treated the same as regular hospitalization. So $200 copay on the lower option plan mirrors that above for just regular hospitalization, no difference. Skilled nursing is, so remember, Medicare doesn't cover custodial nursing, but if you are hospitalized or have some other accident or illness or surgical related event, it will pay for skilled nursing facility for your stay in a skilled nursing facility during this first 100 days. And so this is just outlining the copays for those.
I didn't ever think there was a hospice care copay. You know, I maybe, you know, I don't know where I got that from, but I'm surprised that that's even it. Is that per day?
No, it's just you just enter hospice. You'll remember hospice is end of life care. It's just a single copay. I can make a note. I mean, this is like a free benefit. We could probably just make this zero. Let me just make it out.
You know, at our age, sometimes some people have to deal with that. You know, it's so I
Yeah.
don't, you know.
Mm-hmm. Understood.
Yeah, Don, you know, Steve Cohen's organization down in DC, they're part of a national hospice nonprofit. And again, they're national and all their services are free. So if we need, we can just plug them in.
Yeah. So hospice is defined as end of life care. It's when you have a life expectancy of less than 180 days. So that's the defining event. And so hospice care is mostly palliative. It's not restorative.
Right.
So, but anyway, it's a Medicare mandate. So that's included as such. In terms of emergency care access, these are just the copays. If you have an emergency room, it's waived if admitted. Same thing on the urgent care, $30. The emergency care is the same in both instances. So this is ER room sort of stuff. Urgent care is kind of walk-in clinic or urgent care clinic. There are some hospitals that have urgent care if you know how to navigate going to those. I know in Stanford, for example, they have a separate campus and they have an urgent care facility attached. But so, but that's a lower level of care, much less costly, and again available just through a copay. Ambulance rides. Again, these are emergent sort of care needs. These are not the routine, which we'll hit on in just a minute. They're 70 and 100, same as they had been reflected previously. So here in this diagnostic area, this is something I'll just talk about a little bit. There's two types of diagnostic categories. There's simple basic. So it's basically the diagnostic lab services, it's x-rays, and there's a few other tests that are just considered basic testing. Those are available with a $25 copay in the richer plan and a $40 copay in the less rich plan. They had previously been $35. We changed them. These actually have sort of a meaningful pricing impact. And again, I'm happy to spend more dollars if that's what we want to do, but these are generally at or better than what is available in the individual market. And the complex ones certainly are better than what are available in the individual market. This had been $25, but it costs, I think it's like $6.48 or some number like that to keep it. 25. So I'm going to pause here. You can reflect on that. That's the most significant change we made there, because it's a bunch of dollars that we could grab and spend someplace else and still not lose where we were relative to what's in the individual market. So anyway, 25 base, 50 complex. So this is MRIs, CAT scans, that sort of thing. And on the base plan, 40 and 100. Those were that's where we're.
Let me ask the board, since you brought that up, and it could have been 25, but it cost $6 or whatever more on the premium. Anybody on the board have to deal with any kind of diagnostic services in your plans?
I have.
What was the copay?
I have,
Bob?
I had an MRI, it didn't cost me anything.
Okay. What plan were you in? What plan are you in?
Medigap.
Yeah, plan N, plan G, plan F, plan something.
Plan G.
Okay. Anybody else that had a copay for the bigger diagnostic there, the bigger category? Rodney or Connie or,
I'm looking right now, trying to find it.
okay.
Ray had a lot of lab work done. I mean, like, for years.
But that's in the lower category, right? That's not in the one where, this one here, we're talking about like the MRIs and CTs.
Yeah, he had all that stuff. CT scan, the MRIs, all that.
You remember the copays, Connie?
I'm thinking it's pretty similar to the, I want to say maybe 25 or 50.
Okay, okay.
Let me, I think I might have the paperwork inside. Let me grab one real quick.
All right, go ahead. And Rodney's looking up his stuff. We won't stay on it too long, but just kind of as a comparison, since you pointed that out as a changed item, Don. So I would like
Yes.
the board to have a chance to respond.
Well, something like an MRI, a copay, if it's $50 or $100, is not going to be that big compared to what you would have to, the many times you would have it done.
Yeah.
It's just something you don't do that often. I can't seem to find it.
Oh, they're always scanning my brain. They can't
What
find
do they
it.
Found anything yet, though? have
No,
they?
they can't find anything.
I was going to say, what have they found?
They said there's a big vacuum in between the ears. They can look right through. Well, Rodney, you can keep looking, and Connie, when he gets it, then we'll come back to it. Okay, Don, so you can go ahead.
Sure. And as I say, if you feel it's
Connie,
worth
did you
spending.
find something? Connie, did you find it?
Well,
$100 copay.
I found a bill that I had that I just received, and it was for ECG. I don't know if that would be the same thing. And the charge was $21, but I wound up paying 19. So I guess I got $1 knocked off. I don't know what the heck it is, but that's what I had to pay was $19. Because the total charge was 152, and then I paid 19.
All right. And Rodney, you had
$100 copay, and that's looks like on both different types of plans and Medigap coverage through Anthem
okay.
for complex diagnostic and or radiology visit.
Okay, yeah, that would fit in that category.
If he was getting that done all the time, it might be a big deal, but people don't get that many that often. So $100 copay, most people aren't going to jump on that.
Yeah.
It's outrageous.
I know I couldn't have, not with all the stuff he was having done. A lot. I mean, he had a crap load.
Yeah, I know.
Hope it wasn't crazy amount.
So
Yeah.
basically, I think everybody's saying, Don, that looks reasonable, and it's not going to raise any hair on anybody's neck.
Okay, well, if you change your mind the next day or so, we'll certainly advise. So these next suite of benefits are sort of, they're not all Medicare, they're not all supplemental to Medicare, but they're kind of these ancillary ones that we were talking about. So
Right.
this first one is in fact for Medicare covered diagnostic hearing and evaluation. So there's just doctor visit copays for that. The one that follows it is for non-Medicare routine exams, and the benefit's a $70 benefit. It's a single visit once a year. So it's a modest benefit, but it's for non-Medicare covered benefits. And then the final part on the hearing is there's a once every 12 months $500 hearing benefit that again is available on both benefits. So
Okay.
these last two, the exam and the hearing aid, are supplemental to what you would receive from Medicare. The first one is just reflecting the Medicare copay to do a doctor's visit for something that would be covered by Medicare. Whoops.
Now,
The
if that
next ca-
changes, Don, if that changes in the Medicare expansion, if the legislation goes through and passes both House and the president signs it, and we're going to see a different, this will change to match whatever the legislation is, the final coverage is, right?
Absolutely.
Okay.
Absolutely. So I think what you're going to find is when they get down to the small strokes, that it's going to be a little bit of a battle, because the way that it's structured right now, and at least in the House proposed bill, has them incorporating these additional benefits, the three that we're discussing, hearing, vision, and some level of dental,
Right.
without increasing the reimbursement to the private sector providers. So as you might imagine, they're not entirely thrilled with that.
Yeah.
So lots of advertising against it in the trade rags, but we'll see how it comes out. Probably something will happen, and maybe it won't be on everything, but probably some change will happen. And when that change happens, then absolutely it'll be incorporated in this.
Okay.
So similar to the hearing, the next set is the vision. First is the Medicare covered. It basically just mirrors the hearing. If it's a Medicare covered visit, that's the copay. The non Medicare covered. No, I'm sorry, still on the Medicare covered. This, if it's following cataract, it's a slightly different benefit. And then the non-Medicare covered is the third piece here. So there's a zero copay once every 12 months, and then $100 for materials. And this is where I think Ed's comment was like, is that a discount? It is actually a payment, but if you're paying $400, for frames, then it will feel like basically just a discount, but it's $100 every 24 months for materials. That can be either the eyewear or the frames. Again, supplemental to Medicare. Then mental, this is the outpatient mental nervous. This is the same as it had been previously. Same thing with the rehab, $25 copay in the richer plan, $40 in the lower plan. Medicare Part B drugs. These are drugs that are not delivered through the outpatient prescription drug benefit that we'll get to in a little bit here. These typically are more expensive drugs, and they're delivered in an expensive environment. So they're either delivered in a hospital or other healthcare institution setting, or they're injected or delivered by a physician in some sort of professional setting. So this is the copay for them. These drugs tend to be fairly expensive. $1,500 per injection or something like that. So that's why there's two things. One, even if you could do this in a pharmacy benefit, outpatient sort of, where you go to the pharmacy and fulfill it. And there are a couple of drugs where it is the choice, the individual. Typically, we would recommend, do you want a 80-year-old and self-injecting herself with a $1,500 drug? Perhaps not. So anyway, Medicare Part B drugs, which is part of the standard benefits. Chiropractic services covered at $20, same as it was in both of these. These are Medicare Medicare has expanded and allows coverage for both acupuncture and chiropractic. I will highlight that in the prior thing, and it was because no one paid any attention to it, we had a $5 copay on it.
Yeah.
And it's now 10 and 15. It costs nothing, but I do think it should be like, I don't think there's a reason to have it as a $5 copay to do acupuncture. It's not that it costs anything, it's just that it's strange to have it so dissimilar to just regular services. Diabetes, this is all of the diabetic management. Again, this is Medicare mandated, so it's not like we're doing anything crazy beneficial here, but this is everything. There are packages that you get that include the test strips, lancets, etc. This is a highly used benefit, and obviously will probably be highly utilized in your population as well.
Yeah.
And it's $0 if it's in their preferred, and it's $10 if it's not in a preferred, which is basically anywhere. And you can also get it through a DME provider. That would be the durable medical equipment provider who provides like the glucose, monitors and other sorts of control equipment. All that's pretty standard for Medicare. And again, this is just more on that same topic. Glucose monitor itself, if you get it preferred versus non-preferred, it's $10 difference. DME can provide it for $0. Therapeutic shoes are covered. Again, those are all related to diabetes. Self-management training. This is something that's provided by Anthem. I think it's mandated actually by Medicare that they have to do so. So it's no copay. It's just about how often to test, how to inject yourself, etc. This is a big deal now. I don't know if anyone on the phone, please don't disclose, but the continuous glucose monitors, these are the ones that are connected, and either they're live connected in some cases, or they're just recorded and you download it, or they're attached to an app. So this is becoming more popular.
That's
These
like
are
the things they put on their arms there in the commercials, and they scan it with their phone, and the doctor gets
Yep.
the report to that.
Yep. And it's a lot more efficient, a lot better in being able to identify an issue before it becomes an emergent issue. DME on the higher plan, and DME can be fairly expensive, but it's all available, $0 copay as long as it's Medicare necessary, 20% coinsurance on the base.
Is that going to include CPAP and BiPAP?
Includes CPAP. I don't know off the top of my head if it includes BiPAP, but probably it does. I'm just not familiar with BiPAP as much, but it does include CPAP. And it includes a pretty much wide variety. Anything, I mean, you can look it up, but anything that's covered by Medicare, it'll cover at $0 copay.
They cover both those things.
I'm sorry?
They cover both those things.
Does it?
Yes.
Do you know that, or you're asking?
My brother used them.
Oh, okay, then yes. Yep, there we go.
I use the CPAP as well and go through Medicare first, and the secondary is Aetna, because I'm still under GE insurance. Medicare won't pay for any of it.
Medicare won't pay for the BiPAP,
For the CPAP.
for the CPAP?
Nope.
Yeah, so sometimes where they don't pay for it is if you don't have a diagnosis that would support its need. So there's a medical need that goes with it. But if it's sleep apnea or there's a whole range of them in that category, it would be covered.
You are correct, because they gave my brother a new one because the other one quit. And then they refused to pay on it because they didn't say that the doctor didn't put the right paperwork in. And then they had a hearing about it, and what big to do. They ended up saying it was the fault of the company by not getting it documented from the doctor. So my brother had to pay nothing.
Well, it's good, but he still had the paperwork and
yes,
time.
it is.
Yeah,
It is.
yeah.
That's what I wanted to add. It is complicated, and you do have to make sure all that stuff is done right.
Yeah. So again, if it's part of a covered diagnosis, it should be fine. But I'm not saying mistakes don't happen. And in fact, oddly enough, not for Medicare circumstance, but we had the same thing. And they denied it because it was sleep apnea. Like they literally said, it's sleep apnea. Because of that, we're not covering it. So I actually talked to someone. I said, well, what would you cover it for? And they said, well, a lot of other stuff. I said, give me an example. It was like, the thing is designed pretty much for sleep apnea and related conditions.
Yeah. really.
Yeah.
In
A
any
lot of-
case,
Go ahead.
go ahead, Connie.
I was gonna say, a lot of Ray's DMEs were covered by Medicare. But we didn't pay any copays. We
Yeah,
had to return some of those things, but not all of them.
I'm just gonna have to get a new prescription from the doctor.
Mhm.
I've had it for like 12 years and apparently they've lost the sleep test results and the order from the doctors.
But does your Aetna plan, Brian, does that cover part of the
Yes.
cost? Okay.
Yes,
I wonder if there's because you're still getting the GE plan plus the Medicare disability plan, right?
yes.
That might be the complication, Don. Is it?
Well, I had a supplemental plan, but Medicare paid for all of Ray's, all of those.
Yeah.
That he had to have. The breathing
Yeah.
machine, all that stuff, everything.
So I don't know what the particular challenge was in his case, but here it should be covered, and as long as it has supporting diagnosis. So, if it's not, it's the sort of thing that we're in place to help correct. So, same thing here with some of these other ones. Podiatric services are limited under Medicare, but there are benefits both for Medicare approved and for non-Medicare approved. These are just mostly doctor's visit type things. I've been doing this for 26 years. I've never really understood why podiatric services are limited, but I'm sure it was some committee vote, in the 1960s or something. But in any case, both are covered, both Medicare and non-Medicare approved. Moving to some of these supplemental benefit items, foreign travel. This is more mandated, the emergency part of it. Remember, Medicare only provides services within the Medicare service area, which is the U.S. and its territories. But this provides coverage both on an emergency basis, and I think this is a pretty big deal if we eventually get back to traveling internationally. This provides 60 full lifetime days with a $0 copay or a $200 copay, which is pretty meaningful. I mean, this is inpatient coverage, so which is beyond Medicare. There is a nurse line available. The nurse line is different than the going all the way back than the telemedicine line. The nurse line is more of a, you call up as a patient and say, hey, my neck is hurting me, what can I do? Or, I'm eating this food and it's creating this issue. So it's access to someone that you can talk to about medical stuff, and they have some insights, or they can help direct you to where you can get additional resources. So this is available 24/7. It doesn't cost anything. Routine dental services, emphasis on routine. So this is not, just so I'm clear, this is not drilling a cavity, replacing, putting in a crown, putting in false teeth, et cetera. Those are not covered, but a routine coverage would be an x-ray, teeth cleaning, whatever they call the office visit, et cetera. Those things will be covered. And those are non-Medicare benefits. If, on the other hand, you had, jaw cancer or something, that'd be a medical benefit. So reconstructive surgery, all that'd be Medicare covered, and that would just flow through the other stuff. This is routine dental services that are not covered by Medicare. So these are available under both plans with no copay.
Now that provider right there, Liberty Dental, that's WellCare uses them. And my experience so far with them has not been good. They fight between the provider. My point is this: WellCare approves a benefit, Liberty denies the benefit, or denies the claim, I should say. And it drives me absolutely insane. I have to fight with both of them. So when I see Liberty Dental on your sheet with Anthem, it won't be WellCare, it'll be Anthem. I'm saying, here we go. As far as getting that zero copay, you understand what I'm saying?
I understand, and you have my sympathies in advance. I don't know a lot, don't have deep experience with them, so I
Yeah.
can't comment.
Yeah.
This is what we talked about, silver sneakers. It's a very popular benefit. It's essentially they have a roster of health, what do you call it? Gyms and health club memberships that you can
fitness centers.
access, fitness centers, etc. It's a pretty popular benefit. People swim a lot. People walk and use basic equipment. And
Right.
if you're an active retiree, it's a meaningful benefit. If you're not, then it's obviously something you probably gloss over. So all of these are additional services. Healthy meals. This is just a follow-up thing where they'll provide up to 56 meals, 14 per qualifying event. And it's basically post-discharge if you're coming out of the hospital or other inpatient setting. I think there are some other things, like if you're coming out of chemo, et cetera. They'll arrange the meals for you. So it's a nice benefit in that setting. It's not the world's biggest benefit, but again, it's a supplemental benefit. Adult daycare is the same thing. I don't know if you're familiar with this, but this is if you essentially are in need of I'm trying to use a word other than custodial care, but it's kind of in that category. It's technically not custodial care, but it's essentially it's a professional who will be available 1 day per week and in a supervisory capacity. So that can be helpful. In order to qualify, you essentially have to demonstrate some level of disability. So that could be grooming, continence, mobility, et cetera. And I don't remember what the 6 ADLs are, but you need to have 2 of them in order to qualify. And because of that, I'll say it's a pretty minor benefit in terms of its utilization. Healthy Pantry is actually pretty good. This is a bigger deal than you think. Pretty much anyone who's a cancer patient will utilize this. It's all of the supplemental nutritional stuff that you need if you're going through chemo, and there's some other dread disease issues. So this is pretty good. It's just telephonic counseling and then delivery of necessary nutritional supplements or food. This is the next one, the routine transportation thing I talked about. This is non-emergency. So this is, I want to go to the grocery store. I got to go pick up prescription. I got to do what, prescriptions they can get delivered, and some grocery stores you can, but if you want to go someplace, I need to go to the fitness center, whatever it is. It's 12 trips a year. If anything, I'd get more. It's one of my favorite things. Mobility is one of the biggest challenges we have as we get older, and this is an easy one. Someone, think about it's kind of like having a free Uber benefit.
All right, who's running the microwave in the background? I can even hear the plate rattling inside the microwave.
And then this last thing is something that I actually don't know a ton about, but they have a bunch of, you can go online to the Anthem site. There's a bunch of discount things that are in addition to, not a substitute, but in addition to any of the actual insured benefits. They have some discount stuff for.
Just out of curiosity here, because WellCare did have that, and they had a $200, I think, a month. And if you didn't use it, you could accumulate it towards any of those ordering vitamins, other type of care products like blood pressure machine. I'm wondering how that thing is set up. Not that I want to spend a lot of time on that, but I'm just wondering how that is set up. Is that set up through Blue Cross? They manage it, or is it set up through an outside other company? And there's
so it's available on their site, but I think that most of them have a third party involved. So the vision and hearing have third parties involved, and I think so too do things like
the
vitamins and nutritional stuff. Yeah. I don't think that there's anything where you accumulate like a rewards related thing, at least that I've seen, but I'm not going to profess to have deep knowledge about it.
Yeah. I'm just curious. All right.
Yeah.
No big.
but it is available on their site. I think it's delivered through a third party. So that's it on the medical benefits, and we're about to move to the prescription drug benefits. Before kind of doing that smooth break, and any general comments or questions or thoughts on the medical benefits?
Anybody? Rodney still with us?
Yeah, I'm still here. I'm just looking through
Okay.
comparing plans.
Is Ed still on or did Ed leave? Ed must have left, huh?
No,
No.
I'm still here.
No,
I'm still
everybody's-
here. I just put it on mute. 'cause I had-
Oh, okay. We
We
had
got
to
11
wake you,
people on.
we had to wake you up, Ed. Wake up.
Thank you. I'm up.
Not only is he up, but he is fully dressed.
I know. He's still wearing that tie. He must have another talk with the judge.
Well, they
Must.
don't like you to go.
I had
in
to talk,
the
I had to
fog.
talk to a judge this morning, so I didn't change back.
Rip it off.
Well, at least you didn't have to put on a black robe, so,
Or a wig.
or a wig, yeah, a powdered wig.
Oh,
So moving into the prescription drug area, just again, talking about this generically, or generally, let's say, not generically, that'd be confusing. Talking about this generally, obviously much richer benefits in the preferred, in the high option, the richer benefit plan than in the lower benefit plan, but there is gap coverage in both. They use essentially the same network setup. They have essentially the same formulary setup. Not essentially, they have the same formulary setup. So many of those things are similar. It's just there's more robust benefits and lower copays in the richer category. So overall, our goal here was to, individual plans don't have coverage in the donut hole, which happens after that initial coverage limit, after that 4,430 has been expended. And in the individual market, all you have are what's available through the discounts. And there are pretty meaningful discounts that are offered in Part D based programs now, because they've been forced through law, the combination of the drug manufacturers and other, the PBM itself have contributed to those discounts. But most of that is delivered for generic value, et cetera. So there's full gap coverage even for prescription drugs, even for brand prescription drugs on the richer plan, and just the full generic in the lower plan. So that's among the biggest drivers. In the prior version of this, you saw that there were 5 tiers, and those tiers, basically the additional tier was just something related to how they broke apart generic between some preferred generics and some just more broad generics. Here they're just bundled together. But what is different about this is that where you'll see at the bottom of the page where it says retail 30, that's the full-on 64,000 retail pharmacy network. The preferred retail 30 is a preferred network of pharmacies. Among the biggest that is not a participant, the biggest chain that's not a participant in that preferred retail 30 is Walgreens at this juncture. But it's significantly smaller. It's about 28,000 as opposed to 64,000. But it has a lot of the bigger chains. And if you're able to do it, and it should be, at least one of them should be in most significant communities, not every community, but certainly in most urban areas and most suburbs as well. Exurbs and rural settings, maybe not as fair to do a comparison, but there will be some gaps. But if you're able just to go to that preferred retail, you essentially get your generics for free, and you get $10 off of your preferred and non-preferred brands, and you get about a 5% discount on the preferred specialty. So it's worth taking advantage of. And if you don't want to bother, and you're willing to spend an extra $10, then don't even look at it. Doesn't matter. But that's the incentive. There's a little bit of an incentive to go to that preferred area. And again, so all generics essentially covered with zero copay. And it's a pretty broad category of preferred brands that are available with either the 5 or 15, depending on whether you're in the preferred network or not, on the richer plan. And then the balance of them are at that $35 or is it 50? I forget. $45 level in the non-preferred network. And then there is mail order available. The mail order is Aetna's own mail order. It's called
Anthem.
Did I say Aetna?
Yeah, you said that.
Oops, sorry, I meant Anthem. In any case, Ingenio is the name of their PBM, and it's their mail order facility that will do the mail order. And obviously, if you're taking a medication for chronic, a 90-day prescription, you'll want to have it filled there.
Go up to the retail 30 and preferred retail 30.
Yeah.
Is the preferred retail 30 more the pharmacy chains and the retail 30 like the groceries that offer pharmacy? Is that the split between the two, or the distinction?
No, it's whether you've accepted the lower reimbursement level and you're in the network, and so not picking on them, but Walgreens did not accept it, so they're not part of the preferred network.
Right.
But there are a bunch of chains that have accepted it, and I can send that to you. But there are a number of the big chains that have accepted it, so it's not,
Okay.
and some are groceries like Albertsons, et cetera, but some are, big national pharmacies like CVS. So
Okay. All right.
Oh, but any pharmacy will accept these, right? Not just like the chain ones.
say that again.
So you can take these prescriptions like to a regular pharmacy, not to a chain place.
Yeah, your local neighborhood pharmacy is fine as well. Yep.
Because I know that the WellCare dropped the pharmacy I was using, and they just went with the chain. So I had to change WellCare on somebody else.
Did you catch that, Don?
I did, and the answer is in the broader network, in the retail 30 network, just about anyone you can imagine is in there. It's I think there's 65,000 and change licensed unique pharmacies in the US, or some number like that. Maybe it's 66, and 64 or 65,000 are in. And it's not just Anthem. Pretty much everyone has like the generic contract like that. I don't know if you're dropping a specific one-off mom and pop type thing. I don't know what the reason would be for that. Maybe it's because they rejected a contract or something, but typically they should be there.
Okay, thank you.
No worries. So then there is coverage. This is just talking about what there is. Extra covered drugs are and we did not include this. This is non-prescription sort of drugs, or drugs that aren't have very specific use. I'll say it that way. Lifestyle drugs, for example.
So blood pressure, diabetes, that's are you saying that?
No. Think more like hair growth,
Okay.
vitamin supplements like anti-aging, that sort of stuff.
Yeah, they don't work. I've been using them for years.
Given that you're 700 years old, I think you have to give some
I
credit
look
to
good, hey? Moses reincarnated.
Methuselah.
Okay.
We're doing 30-day limits for retail, 90 days for mail. Special day supplies have their own limits. That's all like wow. So anyway, that's the prescription drugs. And what did I want to emphasize? I want to emphasize something here.
Vision or hearing.
What's the difference between true out of pocket and regular out-of-pocket expense. Yeah,
There isn't any difference. True out-of-pocket means that you have spent out of your pocket $7,050.
yeah. So
And
they're
that's
both-
just that's the level at which catastrophic coverage kicks in
okay, I
from
got it.
Medicare, and
Yeah.
you continue to pay copays beyond that anyway. So it's all integrated.
All right.
It's actually more of a carrier effect than it's where they start getting reimbursed by Medicare.
Okay.
right.
Anybody got any questions on the medical or the prescription plans at this point? And certainly if we have them later, we can consolidate them or whatever and present them to Benistar for answers. I do have, Don, when you get down to the bottom, I mean, you got this blown up to a pretty good size, but when you get down to the bottom in the small print, I call it, when you look at it in the original document, it's really small. And there's some things that Ed and I, or Ed will be explaining to you, there's some things that we want a more descriptive or separate sheet, like evidence of coverage or indemnity statements or stuff that are kind of squashed into this thing in certain ways that we have brought up before, and Ed has brought up from a legal standpoint that we want in the finished product, right, Ed?
Yeah, no, that's exactly right. And I think, I mean, the coverage bits I think are fine. There's a little bit of the language we have to go over. I am going to circle back with both of you, with Don and with you, John,
Yeah.
just to nail everything down and make sure that we're clear. I think some of this is written, Don, from the standpoint of GURBS paying for certain members, which was not the way that we understood this was going to work. But I'll point those out to you and we'll take care of it from there.
Yeah, that's a fees thing that I read too someplace. Yeah. Yeah, we need to understand how that's gonna work out, you know?
And is there going to be a separate evidence of coverage document that's going to be an addendum to the final agreement?
Yes.
Okay,
And each person will get one. It's part of fulfillment as well.
but right, but there'll be like a sample that we'll see along with the
Yes.
execute agreement. Okay, that's what I expected.
It'll be like Exhibit B or whatever.
Right.
And there's actually one for each. And not to be confusing, there's a separate pre-enrollment document, which we try not to mail, but distribute electronically if we can, which we'll share with you. It'll get built as soon as we're final on this.
Okay.
That's a beast. It's is everything you could possibly want to know about.
Right.
It's like 160 pages.
Yeah, I can't wait to see it.
Yeah. It's just it's a Medicare required thing.
Yeah, no, I've looked at them before. They are beasts and they're a pain in the neck to read, but.
So I think I remembered what I wanted to say. There are two things I wanted to say about the prescription drug thing. The first is, and I had started this at the very beginning,
Right, in that summary email. Yeah.
talking about the fact that it will be the number one concern for almost all people as they consider whether they want to join.
Right.
Is my drug covered and where is it covered? And so I sent to Ed, but he can certainly share it with you, just like a 2021 regular formulary that is available electronically and will be available to them to look up, but can also be supported. They can call the service center, and if they have specific drugs, they can look them up, tell them exactly what the copay is and how they can get them. They can also offer them some support services in terms of what it might cost at a pharmacy and whether there's an alternative available. And the thing that I had forgotten that I wanted to emphasize is that because preferred specialty drugs, the average, I think the base in order to be in the specialty category, I think it has to cost like I forget what the number is, $680 per month. So they're $680 and above. So if you have $1,000 drug, just as an example, per month, 28% of that's still $280. It's a lot of money. So in areas like that, what's become more and more popular are a couple of things. First, programs that help you get those drugs that are supported in large part by the manufacturers, not entirely, but in large part by manufacturers, and they're means tested. So for households under $100,000 in income, oftentimes they're very robust programs for that. And so people, before they go and just write checks for that, should, I should explore those sort of things. And the second thing is there's a growing sort of group of bioequivalents that are driving down some of the costs for some of these more expensive preferred specialties. But these are all the drugs that are run nonstop at like 10 o'clock at night. If you're watching television, they're, it's like whatever is 2 generations after Humira, whatever is 2 generations after Enbrel, whatever, and they're 3 times the cost. And for whatever reason, they have figured out ways to, and I'm not saying that they aren't beneficial. Of course they are in most cases, but they figured out how to neatly get them in front of the buying public so that, even 75-year-olds walk in and go like, yeah, I'd like Loprexa. Doctor's like, what? How about we find out what the condition is first? It's like before we go spending $2,000 a month. Anyway, so those sort of drugs, there's support for that, and just wanted to highlight that as well. That'll be one of the biggest drivers, I think, in terms of decision making.
All right, so there's the document that was sent, and I sent on to the board. We just reviewed it on the medical and the prescription, and there's some legalities involved. One of those pages had a signature form or some sort, a small signature form. I assume this is, once Ed and I review it and the board approves it, that we sign this thing and we're good to go.
That'd be good. Yep.
So I would expect, just off the top of my head, I would expect, Ed, would you say a week we should have that done to be able to have any
Yeah.
revisions?
For sure, within a week.
Okay, so that takes care of that piece on the agenda of things that we're going, expectations, timeline. So we're saying a week.
So I have a question and a statement to make, and I just want to make sure that you saw that in Don's email when
Right.
he eloquently stated that we're probably realistically looking at a January 1 start date, because there's so much disruption trying to go off cycle to enroll people and break into the middle of their contract. Doesn't mean we can't start talking about it, marketing and getting the word out, right, Don?
Yes, I mean, that's exactly it. We will, in fact, want to get the word out and whatever, but I think for 99% of people, they're not going to make any change until 1/1, and they'll make that decision because AP starts whatever, October 15th. So it's not, I mean,
Would
it's
you
in
say
that context.
starts the open enrollment you're talking about?
Yeah, the annual election period starts.
Yes,
So,
okay.
yeah.
So you kind of jumped ahead, and that's good, Mike, that, again, the webinar, whether you guys are going to pre-record it or live, the specifics of the marketing plan, which I think are pretty well set, and Glenn can speak to a lot of this, or Mike. I think all this is pretty well set, but when we're looking at it, we're talking about maybe getting into a more intensive marketing phase, website, webinar, middle of September, and then push that through a number of months and then move to actual kickoff or open enrollment, if you will, or enrollment period, January 1st. Does that sound right to Benistar, everybody in Benistar?
I mean, I'm following Don and Glenn's lead on that. Once you give us full approval to go ahead and we have the verbiage, we can add it onto the website. Paul's sitting waiting for us.
Yeah, well, I understood in an email here that you guys had those pieces all in place and ready.
Well, the pieces are in place. The final rates that we just went through you in the verbiage. We didn't have that until you saw it. We weren't going to share it with anyone else.
Yeah, so you're saying none of this can happen? Well, I understand it. We have to review this, legally approve it, board approve it, send it back, sign the agreement, and then we move forward. But I'm saying, moving forward in this timeline, these things that we all have discussed, the webinar, the marketing plan, the actual kickoff date. And I know we did this 4 times already, and I don't want to do it again and then collapse again. So
Mhm.
But you did say in the email, you just said it, Mike, that we're looking at starting maybe, and Don kind of confirmed it, starting marketing so let's say the middle of September, but no actual kickoff till January, which gives us time to breathe and not interrupt other open enrollments or other concerns or
Right. But to your point, when can we start marketing and create webinars and create videos? ASAP. You give us the green light, we can engage. Glenn and I will interface and Don with Paul. I mean, we're just, again, the ball's in your court.
Oh, yeah. Okay.
Yeah.
Anyways,
Right.
that timeframe is accurate, and people will actually be enrolling prior to January 1st. Their benefits will become effective.
No kidding, you're all gonna be behind the 8 ball there.
Say that again, Rodney?
You're all gonna be already have enrolled, so trying to switch in January or whatnot, that's kind of, I don't know how that's gonna work out.
No, they'll make elections under this plan or under AEP, and you can make, in the individual market under AEP, you can make as many changes as you want prior to 12/31. So this stuff will be out to them, and they'll be able to make an election. And what happens is, if you make an election, let's say that you make an election on, I don't know, I'm just making this up, on the 7th of October. Well, not the 7th of October. Let's say the 15th of October, and it gets processed. It goes into CMS. They bump it up against their file. It'll be a change of coverage or new coverage if it's your first time enrolling, but I suspect it'll mostly be change of coverage. They'll then send you out a confirmation of that change. So you, as an individual beneficiary, will get a confirmation back saying you have enrolled in the MAPD Anthem plan, blah, 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 and it'll outline all of your rights. And then if you wake up, at Thanksgiving dinner and go like, I lost my mind. What am I doing? I don't want this. You can disenroll, no harm, no foul. And you can enroll in another plan. And let's say you do that on the 27th of November, you get the same process. And on the 7th of December, you wake up and you go, nah, it was just momentary madness. I want to go back in the plan. You can do it, and they'll enroll you back into the Anthem plan up until 12/31, for a 1/1 effective date. Thereafter, you're correct.
Right.
If you want to make a change thereafter, there are some people that have some special rights to do that. And for our purposes, it's a little bit different than the individual market. You could allow someone to enroll on February 1st if you wanted. So in a group plan, you're not constricted by the AEP, the annual election period. And anytime someone disenrolls, so if they wake up in March and go like, I'm sick of this, those knuckleheads over at Anthem are horrible, I'm going to, XYZ plan, they're allowed to do that. They disenroll from Anthem. It automatically opens a special enrollment period from. That's one of the beautiful things about coming out of group. Automatically opens it for them. They can enroll in any individual plan at that juncture for the following month.
Right. We thought that was one of the Rodney, that we thought that was one of the saleable points about this being a group versus individual market, that you could move back and forth or enroll or at different dates, not just during the open enrollment. We thought that was absolutely one of the better benefits because,
Okay.
I hate us. I understand your concern. I hate us missing the open enrollment period and let people get out then. And then they say, I'm all set. I don't want to change. I understand that,
But underscoring what Rodney was saying, it is better that they enroll during AEP if they can. I mean, they make an election during that period. It's how they're trained to think.
Yeah,
it's
exactly.
you might as well emphasize and be ready for them to enroll during that period.
Okay.
So to be clear, that's what we're saying. We're saying that people will enroll during the CMS enrollment period this fall into our plans. It's just that they become effective January 1st.
Okay.
That's what I understood. Okay,
So
and
we
that
are
makes
in-
sense. And that makes sense.
Yes, we're in
All right.
the main
That sounds
stream
good.
of everything that's going on in the Medicare world right now, to have them be educated, ask questions, learn all about it, and actually make an election this fall as they would in the individual market. So we're playing right to the normalcy of the seasonality of what the traditional cycle is.
Okay. That sounds good then. Yeah. And I think Rodney's right about that concern, and I think that was a good answer that we can have them come in previous to January 1st, obviously. Okay.
Guys, I gotta go. I gotta jump. I'm 10 minutes late for 12:30.
Okay,
Okay,
brother.
good. We'll follow up as soon as we get the paperwork signed.
Thank you. Thanks, Ed. Bye, guys.
No problem.
So all the items in the timeline and moving forward, I think,
Don't forget to transfer
what's that?
the Zoom back to you, to give you back admin.
Oh, yeah. Did you give it back, Don? No, you got to give it back here, or I can take it away, I think. I don't know. Let me see here. No, I can't. It
I
says you
think I
got,
did. I think I did give it back. I gave it back. I exited share screen.
it still says your host on my screen, and when I go to hit more to take it back, it says you got a pin on it. You got a pin number on your hosting?
He's commandeered your computer.
Or you got a pin in your head? Which
He's
one? do you have?
he's downloaded all your secret data, John.
Yeah, right. He's one of them Russian hackers. I know it is. I can't, I thought I should be able to move it, but I can't. It's saying I can't.
Can you just share what you want to share?
Do you have it? Is it back to you now?
Yes. Oh, no, it isn't. Let me see here. Nope, it still says more, and under more it says pin, and it still says host by your name. Good thing you got that, Connie. You'd be in my computer later on, taking all my money and everything, my stock.
Yeah,
On my screen, it says
we're
that
gonna
you're the
need that
host.
babysitting service. on
What's your
that.
screen? What's that?
We'll need that adult babysitting option for you.
I was gonna make a joke about, I
Depends.
got my guy coming at 2 o'clock to, take care of me, change my depends and all that
Good deal.
shit. So Don, you can't get rid of it, huh? That's weird. Let me see if, let me see if I can pull it back. No, it won't let me even pull it back from my name. That's kind of strange.
I've been everywhere, man. I can't find out how to
Yeah.
undo whatever it is.
Well, I don't know if Kenny would know, or somebody would know that once he signs off, I should be able to pull back the control for closing out the video. And
I didn't think you were able to the last time. I don't remember.
well, I hope so, or else we'll lose the whole damn recording.
No, I don't think that you will.
No? All right. All right. So anybody got any questions? I think we've fulfilled our expectations and our timeline and expectations of where we want to be and where we're going. And Ed, you and I got work to do, and then
Yep.
final revisions, and then we, whatever we end up in, Benistar's in agreement, Anthem's in agreement, then we ask the board for approval and we sign off. Okay?
Right, and then we launch the marketing efforts and all the other stuff right after
Yep.
that. Okay, that makes sense.
All right. Very good, everybody.
Right.
Don,
Thank you all.
thanks.
Don?
Yep.
Glenn?
Bye.
Thank you.
Bye-bye.
Don't
I'll
forget to send
talk
me
to you
your
later.
address.
Yeah, bye.
Yeah,
Will
Don,
do.
send her
Thanks.
her address.
Will
Yeah.
do. Thank you.
All right.
Thanks,
Thank you
guys.
again.
All
Thanks,
right.
bye.
Thanks,
Yeah.
everybody. I'm gonna put an end to it, even though Don won't give me back the thing.
Stop the recording.
Yeah, I can stop the recording. You're right.
I don't think you can. I think he has to.
Well, let me see. That's a good question.